Hello, everyone. Thank you for joining us for the Kirby Institute seminar series. My name is Bridget Hare and I'm from the Global Health Program. I'd like to begin by acknowledging the traditional custodians of the lands on which we gather today and where we are recording this from, and pay my respects to their elders past and present. So I am on the lands of the Gadigal people of the Eora Nation, but I'd also like to acknowledge the traditional custodians of the Bidjigal people of the Eora Nation, and to pay my respects to Aboriginal and Torres Strait Islander peoples joining us today, to their elders past and present, and to any Aboriginal or Torres Strait Islander people in the audience online. So a few quick things to start off with. The format for the seminar will start off with a presentation followed by a question and answer session after our presenter has finished. So you can ask questions through by clicking on the Q&A icon at the bottom of the screen. It's now my very great pleasure to introduce our speaker here today, who is Kate Burry. Now, Kate is a PhD student here at the Kirby Institute. So she's my PhD student, and she was also supervised by Dr. Lisa Vallely and Dr. Kirsten Beek. Kate has worked as a sex educator in Vanuatu and Aotearoa, New Zealand, and worked in the sexual and domestic violence sectors. She's going to be talking about her PhD work, which is investigating reproductive injustice, abortion and infanticide in the Pacific Islands. So in Kate's past work, she's led various research projects, including on sexual and reproductive health and rights of sex workers in Luganville, Vanuatu, and barriers to family planning uptake in remote communities in Vanuatu, and also on reproductive coercion in Aotearoa, New Zealand. Kate, welcome. We'd like to welcome you here today and invite you to acknowledge the elders of the country from which you are presenting. Thank you.
Thank you so much, Bridget, for that introduction. Kia ora, hello everyone. Thank you so much for joining today. So I'm joining from the lands of the Awabagalamorimi peoples, and so I would really like to just pay my absolute and utmost respect to their elders past, present and emerging, and to their connection, acknowledge their connection to country and to the beautiful waterways and amazing kind of beaches and everything that we have around this area. So I would just share my presentation. Right, so as Bridget mentioned, so today I'm going to be talking about one particular study that I undertook throughout my PhD. And this is, so today I'm going to be talking specifically around Cook Islands women's safety and wellbeing in the context of abortion. And so Bridget already mentioned that she is my primary supervisor alongside Dr. Kirsten Beek and Dr. Lisa Vallely, and I also had an Cook Islands-based supervisor, Professor Heather Worth, and I really want to acknowledge my community partners, the Cook Islands Family Welfare Association. They were really central to this work and also really central to I want to acknowledge them in terms of the analysis and a lot of the thinking that went into this work. This partnership is crucial, and that cannot be overstated. And also want to acknowledge those who participated in this research as well. I also want to acknowledge that the funding I received for this research from Te Puna Vai Marama, the Centre for Research at the University of South Pacific Cook Islands campus. So today, just briefly, so I'll give a bit of context, a bit of background on sexual and reproductive health and rights in the Cook Islands, just to orientate us, run us through sort of the research methods, and then delve into the key findings and analysis from this research in the Cook Islands. So a bit of background. So firstly, to acknowledge that as with other parts of the Pacific Islands, there is evidence of abortion historically taking place under certain circumstances in the Cook Islands, and usually provided by taonga, or those who are sort of specialised in a craft. So taonga can have lots of different specialties, and some can have specialised knowledge around reproductive health, including abortion. So, for example, on the island of Puka Puka, abortion was reportedly done through physical manipulation. And yeah, so just to acknowledge that there is a context of people and communities taking care of reproductive reproductive health, and that included abortion. So as with many parts of the world, including in the region of the Pacific Islands, abortion legislation and the systems used to enforce were introduced during kind of colonial periods. And so abortion today in the Cook Islands remains a criminal offence. So it's a criminal offence except where the pregnant woman's life is at risk. So that's, we're talking amongst the most restrictive laws possible. And penalties apply for abortion seekers, for providers as well, and also for anyone assisting women in accessing abortion services. Of course, this is in a context where, unsurprisingly, people have sex, and although there's not heaps of research and contemporary research on sexual and reproductive health and rights from the Cook Islands, we do know from existing evidence that from one survey, adolescents, the vast majority reported sexual activity. Again, not overly surprising, but they also reported limited contraceptive access and education. And this largely came down to concerns over privacy when accessing sort of public facilities. We're talking about really small, tight-knit communities. There were also reports around sort of shame and embarrassment around talking about these kinds of topics, particularly with family as well. And also with sort of some threats of, kind of getting a hiding or getting kind of, I guess, physically harmed in the context of trying to bring up conversations around sexual and reproductive health and sex and relationships. In this survey, there were concerns among young women as well around sexual consent. So 70% of young women in one survey reported being pressured to have sex. And an internal report also sort of observed a relationship between adolescent pregnancy and having suicidal thoughts, and also with sort of physical violence and rejection by the family. So, for example, also being made to move away or move in with or marry the sexual partner or the father, the person responsible for the pregnancy. So these are just important contextual information for what's going on for in the context of, I guess, particularly adolescent pregnancy in this instance. Also, just to point out that their internal surveys have also found high rates of intimate partner violence. So about a third of ever partnered women report intimate partner violence. In this survey, they also found that there were higher rates of those who reported lifetime intimate partner violence and who also reported lifetime experience of abortion. So 4.7% of those who reported lifetime IPV also reported abortion. So there is some kind of evidence, some kind of creating a picture of the need for abortion services despite these legal restrictions. There's also was a study of 10 young women's experiences of teenage parenthood. So although this was about teenage parenthood, this study, some participants also brought up attempts to access abortion services as well. It sort of emerged as a theme, and largely they discussed travel to New Zealand or sometimes to Australia. Travel to access abortion services requires a lot of financial resources and other kind of resources, time, for example, and these restraints were often insurmountable. So others sort of reported attempting abortion through self-harm or sometimes through taking kind of plant-based mixtures. Although, these were not often painful and dangerous, but not effective. So that's kind of just to provide a bit of a picture of what we do know, but also to acknowledge that there is really not much understanding around abortion for Cook Islands women and what that experience is like in the context of restrictions. And so that brings us to this study and to the work that I did with the Cook Islands Family Welfare Association. So We undertook a qualitative study just on the island of Rarotonga from between February and August in 2022. So the idea was really to understand, gain a sort of depth of understanding of what were the pathways, what was involved in decision making, what were all the obstacles, what, all of that kind of detail, which is why we pursued a qualitative study. And so we included one-to-one interviews with women, and they included women who had accessed or who had tried to access abortion services. We also included those who had supported women to access abortion services, advocates as well, working in sexual and reproductive health and rights, as well as health workers. And focus group discussions we also included to understand just sort of broader understandings, perceptions of sexual and reproductive health and rights, including of abortion as well. So women from those three age groups, 19 to 22, 27 to 36, and 50 plus years. So I'll now go on to talk about some of the key things that we found in this study. So first of all, our findings more broadly in relation to sexual and reproductive health seem to kind of sort of support the findings of the studies that I mentioned earlier. So participants described limited access to sexual and reproductive health education, including, sort of the physiological changes around puberty, sexual consent and contraception. They also discussed sort of shame and fear arising from the topics of sexual and reproductive health. They reported threats of hidings or sort of I guess physical abuse particularly by families if they kind of did raise the topics of sex or relationships or wanting to access contraception or having kind of questions around that. But of course, young people want this information, they need it, and so participants reported often turning to friends, sometimes older friends that had more experience. I had many kind of quite funny conversations and relatable conversations around looking at magazines to try and get information as well. And some participants, but particularly the younger participants, also discussed pornography as something that they were sort of aware of and sometimes concerned about. So particularly around young men accessing this. And sometimes it was more for entertainment value. They expressed concerns as well around what that meant if there wasn't anything, any kind of good comprehensive discussions and education alongside, viewing that material. And some of them had been exposed to pornographic kind of videos and that kind of thing that they did not want to see. And this is just reflecting issues that I guess we're all probably aware are larger than just the Cook Islands context. So just to kind of bring some of these points home, I've got a couple of quotes here. So this is from the focus group discussion with young women aged 19 to 22 years. So in this, I'll just read it out just for ease. So it's meaning education regarding sexual and reproductive health taboo, because they think that exposing kids to that information encourages them. But that's not true. The goal is to inform them. Exactly. So then, they know if something happens, they know what to do, not to have to hide it and go around. And they go really young, who get taken advantage of at young ages. And you only have 1 or 2 sessions talking about sex ed, and then you won't ever see it again. So yeah, I think kind of the important points in this sort of speak for themselves, including around not having access, the impacts of not having access to information, and what that does and what that means as well in terms of the vulnerability of younger people who don't kind of have that information and that sort of support. Got one more here from the slightly older cohort. So the 27 to 36 years. Because in my household, me growing up, talking about relationship, puberty, and stuff like that was taboo. It was something that my parents was very uncomfortable. If I ever mentioned about a boy, I would be getting a hiding, nothing like that. I basically learned it from my friends in school or my friends that are a couple of years older than me that's already got a boyfriend, and they'll be like telling me all these things. Because I got my period at a very young age. I think I was like 9 going to 10, and I didn't know what was that. I'm like, am I dying? So my mum came with this rag and just put it in and make sure when it's like, when it's soaking, you go and rinse it, and then we'll wash it and I'll cut you another one. But no, like, this is part of nothing, no messaging. So again, I think that sort of speaks for itself and what perhaps some of her needs were in that context. Around what information and services participants did report. So the first thing was participants did talk about navigating and accessing different contraceptive forms of contraception. There was quite a bit of discussion in interviews and in focus groups around finding tolerable side effects. So perhaps space in there to kind of assist with understanding and setting up expectations, but also having a range of different options available. Participants also did bring up the role of SIFWA, of Cook Islands Family Welfare Association, so who were also the research partners in this, and they brought this up spontaneously. They were a non-government organisation and were observed both in but also outside of the research context as being really, really important and kind of helping people to access information and services to the extent that they can with limited staff and facilities. So this was often accessed through friends and relatives, and they helped with increasing understanding and but there was also some participants did sort of acknowledge a bit of a lingering sense of shame. So, for example, going through the back door of to access the clinic rather than through the front door and trying to park around the back and not be seen because, yeah, they're sort of where they're positioned on the main road. So kind of important sort of complexity there as well. And participants also reported frustrations over male responsibility regarding contraception, including in some instances where that led to the unplanned and unwanted pregnancy. On to the findings specifically related to abortion. So participants described overlapping reasons for accessing abortion services, with unsurprisingly clear insight that continuing their pregnancy and giving birth would have brought shame sometimes upon themselves and their family. I'll talk a bit more about shame in a moment. And it would have caused like hardship in different forms, distress, significant disruption to their lives, education, careers, training, and other goals. Most, if not all, described unstable, sometimes unequal, unreliable, or sometimes non-existent relationships with the sexual partner, which is also really important to consider as well. So some sort of were fairly isolated in this experience. From there was this, given the legal restrictions, also given the really small and tight-knit community on the island of Rarotonga with a population of just over 10,000 people, the process from there, the pathway from there to sort of accessing information and trying to find out what do I do in my situation, what are the options available for me, was a careful process and necessarily selective. So one participant, for example, described like, I've got my friends that I grew up with, that I play sport with, and then, I go out drinking with and that I party with, but there was no way I was going to talk to them about what I was going through. And then she sort of spoke about, she was like, then I've got the friends who I know will be there for me and be non-judgmental and just sort of support my needs. So yeah, that necessarily kind of selective disclosure for support. And also, with the like, who's going to give me the information that I need as well. So from there, participants described 3, I guess, key pathways to accessing abortion services. And the first one was reflected in the study of teenage parenthood that I mentioned earlier. And that was travel to Aotearoa, New Zealand, or sometimes some accessed abortions in Australia as well. And I just realized that one thing that I forgot to include in my context is that there is a difference, sort of a uniqueness for Cook Islanders in that they have New Zealand passports as part of an agreement between, that's kind of got a history as well. But essentially, Cook Islanders have New Zealand passports, so they can go to New Zealand and to Australia to access public health care. Interestingly, from this research, there seemed to be sort of this general awareness that people, particularly young women, go to, but are also taken to New Zealand in particular to access abortion services. And so, but it's also sort of swept under the carpet in a way. So it's kind of, they go there for a checkup. I think I've got a quote about this soon that kind of basically states this. Sort of, yeah, swept under the carpet. They go there for a checkup. They, meaning that they go there for an abortion and then they come back. So there is sort of this underlying but unspoken awareness that was something that I observed in this research. But of course, we're talking about significant costs. Some participants accessed abortion during COVID lockdowns as well, so they had to navigate additional costs and additional constraints on access to healthcare, which was complex. Logistically, it's really complex. You know, if you know, you're unfamiliar with Auckland, for example, which is where a lot of people go, you know, how do you get from potentially, you know, staying with family members to the clinic? And, you know, is it public transport? Do you have friends or relatives that are going to support you? Or do the friends and relatives in New Zealand also not really know what's going on? What happens if you start bleeding on the bus? Lots of kind of factors in there as well. And it also speaks to sort of health inequity in terms of the cost, but also for the migrant population as well. So those who are coming over to work in, you know, the hospitality and tourism sector. There was one migrant worker included in the study who had an abortion as well. And so I think that's kind of important. What options are actually available for people in these kind of restrictive settings? I will say though is that participants who accessed abortion in terms of the medical care they received in New Zealand and in Australia, they did reply sort of very kind of professional. It was very quick and painless procedures. Everyone who had the abortions in New Zealand and Australia had surgical abortions, so that's an important point as well. That if they were able to access, that was the experience overall. The next option is around what was medical abortion, and this was an interesting, my sense was, emerging form of abortion in the Cook Islands that from this research became more of an option that people sought out and explored or even learned about during COVID-19 lockdowns as well. Again, this is just from those included in this research and discussions in the community. Again, this option did appear to be also reserved for those with the right networks in their community who knew about this option and knew what to do. And there's also a big piece in here around learning about it, having the support, but also around timeliness. So being able to kind of go through the online consultation process and get the medication via postal service to a small island in the Pacific under 10 weeks of gestation. So that was really, you know, there's lots of kind of elements in there. And also in terms of actually undertaking the abortion, the medical abortion, finding a private location in which to undertake that. And then during the abortion, having the support in place, which was really big. One, the migrant worker in the study was alone, and she and others who had medical abortions, they were safe. No one required follow-up care. But no one felt prepared. No one described being prepared for how painful it would be, and needing to kind of know that things are okay and things are progressing normally was really important. But of course, that those kinds of supports are not available where abortion is largely illegal. And then there were the other methods that were mentioned were, I mentioned taonga before, and so some participants in the study also tried to access taonga for abortions. One support person supported two friends to access abortions through a taonga in the community. So taonga, participants described drinking 3 1.5 litre bottles of some kind of unidentified liquid. They also described receiving prayer and massage, and also being under instructions around behavioural restrictions. But it didn't work for any of the participants in this study, and it did cause sort of some nausea and other side effects. And then the other option was, so quite a few reports of alcohol poisoning as an attempted method for pregnancy termination. And one participant described drinking sort of excessive amounts of coffee. And she also reported that that was successful at inducing abortion. So those were, yeah, we can kind of see the sort of different levels of what's available for people, and, you know, big questions and around sort of health equity in terms of access, and who has the right kind of social networks and support and resources. So I'm now going to talk a little bit, sort of my final kind of major points are around the kind of socio-cultural context, I guess. So I'm just going to start with this quote from a participant who had an abortion. I come from a religious family, yeah, and that used to be me. I used to be like, abortion is a sin, you know? And I'm like, I'm always against it. But when it happened to me, I was just like, I can't do it. I can't go through with this pregnancy because it's wrong. Yeah. But when the abortion actually happened, I just cried. Yeah, I don't know how to say it. It was quite hard to go through. Yeah, because of my cultural background and my religion and my family. Like, not many of my family know. So that whole experience was scary for me at first. So as this participant reflected, and as it was sort of universally sort of described in this research, there is a widespread belief that abortion is a sin. And one participant sort of put it to me like, abortion it's a sin, but it's such a sin that no one even talks about it. So it's not really up for sort of public debate, if you like. On top of that, participants reflected in different ways on a, a sort of key value, cultural value around selflessness, around decisions. Yeah, sort of your behavior is reflective, not necessarily of yourself, but actually of your family, of your family's worthiness and sort of competence to raise a child who behaves in idealized and valued ways. Participants reflected, one participant in particular reflected on this in terms of gender and what that meant for women. And as that particularly intense, that's me sort of paraphrasing what this participant reflected on. And the idea of sort of young women sort of exhibiting grace and humility, being sexually modest as well, if not virginal. And yeah, the importance of that in the context of protecting the families and the family and other important community networks, protecting them from any kind of shame. So shame, of course, being shared in this context. So it's not just reflective on the individual, but kind of a larger network of people. This also sort of reflects this tension that kind of came out of this research between the personal context of participants' sexualities and pregnancies and abortions, and sociocultural context and values attached to this. So I had quite a few discussions, and I don't have time to kind of go through this in detail, but around akama, which is very crudely translated as shame, but it's a bit more broader encompassing and kind of reflects more of that kind of shared and communal element. And also discussions that I had around akama also were, you know, Akama is sort of reflecting 200 years of missionary and colonial involvement as well, and the influence of missionaries. Missionaries introduced really harsh punishments for lots of different things, including sexual transgressions in many parts of the Cook Islands, and that was continued in some cases throughout the sort of colonial period. So that's really important to reflect on, I think, as well. Also on that sort of to reflect on shame a little bit more, participants also reflected on shame in relation to sexual behaviour and pregnancy as in a different way as well, and specifically around abortion as saving the family from collective shame in some instances. So particularly in the context of adolescent pregnancy, if we're thinking about this idealised sort of ideal of sort of young women as sexually modest, and sometimes, you know, older women as well, but I guess just thinking about adolescent pregnancy in the context of a pregnancy for a young woman, it might be part of that sort of, I guess, shame management, if you like, to go and sort of, yeah, go to New Zealand and sort of seek out that abortion service. So this is one participant reflecting on what I've just described then. Some families with teenage pregnancies, and because of the embarrassment and stigma, they would just fly the teenager down to New Zealand if you've got the money. It's all under the carpet. Fly down. Oh, she's gone down for a medical checkup, but that's what it is. They're booked into a clinic, terminate, spend a month or so down there to recover, recuperate, and then come back. So we're getting, hopefully you're getting a sense of the layers and the kind of complexity of a lot of this, the data from this research. I want to end on one really, really important point to bring us back to a sense of cultural safety in summary. And I want to really hone in on the point that, you know, participants' relationships to their cultural context in this research was not just one of shame and of akama. It actually was also, many participants reflected on some of the most poignant moments being about the support that they received. And this was in lots of different ways. So this kind of rebuilding of sense and of safety in culturally embedded ways is what I want to kind of finish on today. So support people had, you know, extensive involvement in terms of the logistics of everything, but also in terms of emotional support and in being there and in just servicing the needs of others. And this challenges this sort of universal association of abortion with sin and shame, which is why I feel like it's important to kind of end on emphasizing this. Participants also reflected on, you know, their emphasizing of the personal context of their pregnancy, and sometimes also navigating and thinking about and reflecting on sort of the role of others in their decision as well. So in this way, it kind of brings about another cultural kind of value to reflect on, and what I'm going to be kind of focusing on in this closing, which is that of aroa. So this kind of idea of this sort of bravely supporting the needs and looking after the welfare of other people that was reflected by support people, but also in participants when talking about the support they received. But of course, that's also, we're talking about lots of different levels and scales of support that people did receive. Some people were more isolated, and some people had more of the sense of sort of cultural safety in this way. So again, there is inequity in terms of the level of support. So I've got a couple of reflections on support people. So this is from one participant about support people. So there were only certain people that know. There have been little more now, because I feel like I needed to tell, but only again to certain people that I trust. And that has sort of helped me, because I feel like I'm just holding this in, and it's draining me as well. Like, I don't want everyone to know. No, I don't want just those that I trust. But yeah, since then I've told a few of my friends, and they've been supportive of me as well. yeah, so that's been nice. But yeah, no one didn't really know, just my parents, my siblings, my cousin, and just my close friends. That's it. And how were they in terms of, you going through this experience? They were really supportive. They'll always be here, and they will always message me every day about how I'm feeling. And after the surgery, they'll keep messaging me and sending me love and prayers too. And I would cry sometimes just reading their messages because I know they will always be here for me. When I came back, they were they were not they were just not talking about it, but just asking me if I was okay and things like that, buying me little gifts and yeah. So again, this idea of kind of being welcome back, and that second quote was that young woman travelled to New Zealand, and so she was reflecting on coming back. This idea of being welcome back and others kind of sometimes bravely, if we're thinking, factoring in the sort of the context of sort of abortion being considered as sin, but also a crime. So bravely supporting others' well-being and supporting their needs. So if we're thinking about sort of this like idea of shame as being kind of like or or akama even as being kind of reflective of someone being outside of norms of gendered behavior or values or ideas of worthiness. This is kind of the opposite of that. It's like this idea of welcoming back in and remaining part of communal and cultural life and including spirituality, if we're thinking about that last quote around receiving prayers. And I've got just a couple more quotes just to end on, and I'm aware that we're nearly at time, but just because I think this reflects on the importance of this idea of welcoming back in. So this participant had an abortion in Sydney, and so was reflecting on after that. I just put little touches, island touches in the flat, Cook Island touches, like a sarong. I pinned it on the wall, a picture of the Cook Islands and that kind of thing. So I had and Cook Islands woven hats. I felt that warmth, from the sarong, from the pictures that I have. Again, coming from that, I would say very sterile and cold environment of the clinic, even though I was only there for a few hours. And they had an Indian grocery store, and they sold taro. I don't know where they got the taro, I guess from Samoa. So I went and got me one big one, and I took it and I just took it and boiled it. And I guess it's like reconnecting to some kind of warmth, some kind of island Polynesian feel. This participant also had an abortion overseas in New Zealand, and she described meeting this other Pacific Islander young woman who was really, really distressed after the abortion, and they met in the recovery room. And this was part of a larger dialogue, but this was kind of part of her reflection on that interaction and what she could provide. I felt good that I was able to console her there because it felt like something I needed to hear as well. Even though I'd come to terms with everything and was set in my decision, I felt like she was that part of me that would have regretted it afterwards. So in comforting her, I felt like I was doing myself a service. That moment has stayed with me since that day. I think I was just meant to be there at that time. So it just shows again that generosity of serving others, of those important cultural values as well, and that how that reconnects people in an almost untangible way in relating to that kind of someone with sort of a shared cultural background in that context. And then this final one, just to kind of finish as well, there is actually room there for things like that, where certain things where you can decide between and something becomes something between you and your God. It doesn't have to be between you and the church. So this participant was, as is probably apparent, reflecting on this kind of generalized notion of abortion as sinful and kind of reflecting on her experiences. She had 2 abortions in her lifetime, and finding her own way through her beliefs and her experiences. So I think just to kind of leave with some reflections, without probably doing them much justice in the sort of 2 minutes that I've got. But I want to kind of leave you all with this sort of justice potential, I guess, of engaging with these culturally embedded values, in terms of, engaging with the needs of reproductive needs of people, including and importantly those who don't have normative pregnancies or normative sexualities, who don't necessarily fit in with those kind of those kind of norms, I guess. And also welcoming in that idea of welcoming in and caring for those who have diverse goals and needs and complex things going on in the context of pregnancies, which participants reflected on. The justice potential as well of this kind of communal, interpersonal kind of approach of welcoming in those who are marginalized by norms, by laws, beliefs, and other structures as well, for example. And thinking about the kind of importance of culturally embedded values that resonate as well. And so for my discussion of aroa has come up so much, I guess, as well, because it came out of discussions that I had when I went back over with the report. And there were definitely nods of familiarity around talking about akama and how that, that's really on people's mind, particularly the women that I've spoken to, really on their minds in different contexts. Am I behaving in the right way? And one of my kind of advisors, Makiuti Tongia, spoke about akama almost like different shells, and that he sort of said that women particularly have to navigate in different places and trying to navigate that complexity in this kind of very relational and sort of communal context. But then when I spoke about aroa at the report release, there was almost this emotional shift of sort of lots of soft mms from people in the room, of like that being really resonating. And I'm not saying that this is, what reproductive justice and reproductive rights movements would look like. I'm just saying that it's important that they are engaging at that level, and also just to acknowledge that, a lot of this inspiration came about from Sifu's work as well, and how they navigate, their service provision in this context as well, which again really speaks to the idea and as I've said, the justice potential of that kind of interpersonal and communal relationship building type of process, and rather than, I guess, thinking of it in terms of universal pro-choice movements that may not resonate so much. For example, that choice can be complex when you are factoring in lots of different relationships that are important and that kind of thing. Although, of course, participants reflected also a strong sense of the importance of autonomy in terms of decisions and being able to have a say as well. But these things are complex, and of course these are constantly emerging contexts and constantly shifting and changing. And I had interesting conversations as well around how young people were navigating the sort of shells, as I described before, in different ways, and resisting and finding ways around it, and welcoming people in and into their network, and how that hopefully getting a sense as well around like how that could spring kind of more justice for those who are marginalized. So I will finish there on hopefully, I hopefully haven't kind of gone too far in those last points. These are still ideas that I guess I'm still exploring with partners and with those in the community. This is a link to the report, and we also have a paper in Culture, Health and Sexuality, which sort of explores some of these issues as well. And also do feel free to contact me if you want to chat further or have further questions. But I believe we've got some time as well. 15 minutes. Hopefully that's
Thank you, Kate. Yes, Yes, we do. And we have a couple of questions that have come through. I'll start off with our first question, which is from El Cooney, who unfortunately has had to leave. But I think it's an excellent question. I think many other people will be wondering about this.
Oh.
And this came up in response to when you were talking about people people discussing sex education. And the question is, did interviewed people in older age cohorts say when they were discussing with their own children, did they take a different approach with their own children as they grew up in terms of sexual health discussions?
Yeah, interesting. Good question. Certainly one participant described taking a different approach. Yeah, I do recall one participant sort of saying like she wanted to have discussions with, particularly with sons. And I think that that is probably um, an interesting idea and thing to research further. The focus was often mostly around abortion for this particular research, but I do think that those shifts and those changes are really important to explore and could be certainly an interesting space for future research. Yeah, as I said, I do recall one participant in particular discussing that she was trying to be much more open with her young people and saw it as, again, that's part of looking out for them in their lives and their community. And because of her, she had, quite significant traumatic experiences that she also described. So I guess that was part of her, like, you know, caring and looking out for them as well. So yeah, interesting, big question. Yeah.
Yeah. Another question, this is from Rachel Smith, is who provided or arranged the medical abortions on the Cook Islands? Was it MSI, Murray Stokes International?
Good question. And so sorry I didn't say that. Largely, Women on the Web was reported to me as the providers of this service. So yeah, apologies for not saying that, but that was mostly what was reported to me. So I'm not, yeah.
And Kate, a follow-up to that was you talked very warmly about the Cook Islands Family Welfare Association and their fantastic role. Did they have anything to do with actually linking people into services? Like, for example, if there was a young woman who was seeking abortion services, would they help link people up with appointments in New Zealand or anything like that?
So probably limited in terms of what I can ethically kind of talk about here, but I mean, certainly in terms of providing, of course, post-abortion care, they did do screenings for those who had had medical abortions, for example, to ensure it was complete. Um, there was an incident in the Cook Islands with a healthcare provider who was linking women up with services in New Zealand, who got a pretty public slap on the wrist for that. And so I guess for healthcare providers, and thinking about what they can and can't do for those who are motivated and trying to support, their patients in that way and trying to support their access. There is, although there have not been any sort of charges or prosecution, certainly no kind of prosecutions under the abortion legislation. There is kind of there was that incident. So I guess that's kind of part of the context. Yeah.
Yeah.
So yeah, that's probably all I can say on that front. I'm
Yeah.
happy to
So
talk privately as well with people, but yeah.
yeah, okay. So it really is complex, and that legal, the legal context really does set up what is possible, to do in various ways. Yeah.
That's perfect summary. Thanks.
Kate, I've got a question from Rinaldi Ridwan, who is asking, was there, and this is a process one, any of the participants that you spoke to, did anybody experience personal distress when they were talking? And if they did, how did you work with that?
Thanks, Rinaldi, a fellow PhD student, also in the sexual and reproductive health and rights space. Yes, some participants did experience some distress. Not always. Some were quite almost sort of matter of fact. And there was nothing that really determined that. So, for example, age didn't really determine that. For some, it was, for some of the older women, it was still the first time they'd actually spoken about it. And so in terms of that, so there were a couple of sort of ongoing ways in which I supported and was conscious around that. So the setting up of the interview space is really important. Ensuring tissues are really easily within reach and water is easily within reach. And setting up in terms of, I would sort of say when I was about to ask something that might have been a bit more sensitive. So, for example, if I was about to ask a follow-up question around the actual abortion, what was that like? Or, can you tell me more about, when the abortion actually started? I would it's almost kind of put in like a warning, not really a warning, like I'm just going to follow up a bit about this. You don't have to answer this question if you do feel uncomfortable. So sort of just giving people a little flag, lots of opportunities to opt out and to step out and take a break. I also had, and I undertook most of the research interviews in all of the research interviews with the women were in the CFWA facilities, and they had a counsellor available, and so who knew about the research and was available for those afterwards. And so that was something that came up for some. For some, it was, they reflected that it was, for those who did get a bit upset or got emotional, they reflected on the catharsis of that it wasn't necessarily a negative thing to express and show emotion. They were just dealing with sort of all the complexity that I tried to get across in this presentation. And so, so hopefully that helps. Rinaldi, really, I can only see my Bridget's face, I can't see your face. But if you do want to talk about this more in terms of your own research and how to kind of support people and how to manage that, like really happy to talk more. Not saying that my approach is perfect, but that's sort of some reflections, I guess. Yeah.
Hey, I'm going to squidge a couple of questions together here so that you get to hear what everybody else is asking and get a chance, because we've got 8 minutes left that we can use. So there's another follow-up question from Rinaldi, who is asking about ethics clearance given the illegality of abortion there. And we've got a question from Virginia Wiseman, who is asking about feeding back and sharing the results, specifically asking about government. Virginia also asks about other stakeholders, and I think you've mentioned that. But so there's the question about government, and there's the question about ethics given the illegality. So if you're able to address those, that will be fantastic. Thanks.
Great. Yeah, always the fun topic with like researching illegal things. So I did go through the internal ethics review process and got a permit in the Cook Islands. Unfortunately, it was supported without issue. Which is interesting. I've had similar experiences in Vanuatu, which is initially where I was meant to do this research, and which is interesting. And I kind of can't really say much more in terms of, I'm not quite sure why. I know in Vanuatu there is a focus on, in the Ministry of Health kind of plan around looking at impacts of unsafe abortion. There is no, as far as I'm aware, no particular focus on abortion and abortion legislation. CFWA did try to change the law. They're one of the few organisations in the region that have tried to do that. They did a bunch of consultations, and it was rejected outright. There was no listening to that. So there's the political landscape in terms of even bringing it up for debate. It just seems really complex, and that's kind of probably a bigger discussion. And then in terms of the release and the kind of political engagement, so yeah, the report release, and all that side of things, the political side, the release and how the report is managed, that's really under the control of Cook Islands Family Welfare Association, and that's a really big part of that, I guess, partnership approach. They've got a really, really careful, and I think amazing, and for me, fascinating process of how they engage politically. And that's that they have quiet allies in the community, and they navigate hierarchies and relationships in this very obviously sort of culturally embedded, but also quite careful way. So in some recent email correspondence, for example, one of the CFA staff put it that something like, we're just going to continue our sort of go slow and stay low approach. And I think this is worthy of, and it's something I have explored with other advocates in the region, but yet to do anything about because I've been trying to finish my PhD. But I think there's something to be said around how do organizations in these contexts navigate advocacy for topics like abortion, which are not up for public debate because they're sort of a sin. And I think when I think of advocacy, often from my cultural framing, I think of, demonstrations and engaging in that way and protest. But maybe that's not suitable. Maybe this quiet and slow approach of dialogue, of meeting with people, of finding your allies, of just kind of quietly and over time and in that sort of very grassroots way, as CEFWA sort of do, maybe that's sort of an interesting thing just to throw out there. So in terms of the political side, that's kind of what it looks like in summary, and it's very much led by them because of how intertwined and I guess sort of complex, delicate it is, and beyond me, really, beyond So hopefully that sort of
Thank you. That's a fantastic answer. I think you've really brought out the importance of nuance and of the community owning the advocacy agenda and actually being able to direct that rather than, and you've done the work in providing the research, but you've done that in a way that's culturally sensitive, and you're an ally with advocates, but you are enabling the community members to discern what is the most productive way to go forward, which I think is fantastic, and there's a lesson for us in that. Kate, we've run out of time. Thank you so much for your presentation today, and I'm sure on behalf of everybody I can congratulate you for submitting your PhD. We are all looking forward to being able to call you doctor when next.
Thank you, and thanks to you, Bridget, for being my support or ally throughout this. Yeah, and thanks everyone for attending and for your interest. Do get in touch if you have follow-up questions. Yeah, thank you.
Fantastic. Thanks, Kate. Thank you, everybody.